Good day and welcome to today's CMS-CDC Fundamentals of COVID-19 Prevention for Nursing Home Management. This is the live Q&A session. Please note this webinar is being recorded. All participants are in listen-only mode. If you would like to ask a question, please enter it into the Q&A panel located at the bottom of your screen. It is now my pleasure to turn the call over to Ms. Lisa Sullivan. Please go ahead.
Thank you. Next slide, please. Good afternoon, everyone. My name is Lisa Sullivan, and welcome to the live Q&A session, which is associated with the CMS-CDC Fundamentals of COVID-19 Prevention for Nursing Home Management training series. The very last topic, which is COVID testing, will be posted to the QIOprogram.org website by tomorrow morning. This live Q&A session is dedicated entirely to interacting with participants, sharing comments, and taking questions, and are intended to supplement the online training topics and provide nursing home personnel with an opportunity to ask questions of CMS and CDC as they navigate through the pandemic. Thank you for taking the time to be with us here today, and a special thanks goes out to our CDC colleagues for partnering with us on this important training series. Please note that the slides from today are available on the QIO program website, and the recording from today's event will also be posted there within a week, so please be on the lookout. Next slide, please. Please be aware, registrants of the training series can email the Nursing Home Trainings inbox for support with any questions for certificates, self-assessments, or issues accessing the on-demand training, and that will be put into the chat box, but it's also on the screen. And the email is nursinghometrainings@thebezelgroup.com. Next slide, please. It is now my pleasure today to introduce some of the featured panelists on the call and assist us with answering questions you may have. Today, we are fortunate to have the following CDC colleagues joining us: Dr. Namali Stone and Dr. Kara Jacobs-Slifka, our fellow CMS SMEs and COREs, Angel Davis, Marianne Butcher, Nancy Allard, and myself, along with a few co-workers from the Division of Nursing Homes here at CMS, Kathleen Lawrence and Sheila Hans. Next slide, please. We are also joined today by our previous speakers from Rockport Healthcare Services, who presented on the September 24th session, Creating a COVID-19 Recovery Center. Dr. David Silver, the Chief Executive Officer, Dr. Michelle Eslami, Chief Medical Director, Carol Larkin, Rockport's Chief Clinical Development Officer, Kristen Morris, who is not pictured, who is the Chief Clinical Officer of the Rockport Group, and Lindsay Holland from the Health Services Advisory Group. If you have any questions regarding creating a COVID-19 recovery center, this is a great day to get those questions answered. Now, we have received a few pre-call questions that we plan to discuss, and thank you so much for those submissions. But we would also like to encourage you to get involved in posing questions for us to address while live. Please look at the bottom of your screen and see the Q&A box. Click on that box and enter your questions, and we will address as many as time allows today. Without further ado, let's get started, and I will turn this over to Angel Davis.
Thank you, Lisa. So the first question is around visitation, and this question is being posed to the CDC. What do you recommend in regards to social distancing guidance during end-of-life visits? Can a family member hold a dying resident's hand if they have used ABHS?
Hey, this is Kara Jacobs-Slifka. So CDC does have some general guidance for visitors, which includes things like visitors should wear a cloth face covering or face mask whenever they're either inside or outside of the nursing home. If they're doing some kind of visitation, they should be screened and asked about any signs or symptoms when they're entering the building, and they should perform frequent hand hygiene. But for your second question about holding a dying resident's hand if they've been using alcohol-based hand sanitizer, I'm going to answer this as both an infectious diseases physician, but also as a mother, a daughter, a sister. Hold their hand. I think if you're really concerned, you could encourage the use of gloves, but honestly, I think that with a family member wearing a cloth face covering or face mask, avoiding touching their face and performing hand hygiene using either soap and water or alcohol-based hand sanitizer, both before they touch that resident and immediately afterwards, I think they should be able to hold the hand of.
Thanks, Dr. Jacobs. The next question is going to be, again, for you and Dr. Stone on the subject of visitation. If they are cleaned well, can facilities create a hug station so that long-term care residents can hug their family, friends, as one of the solutions to the lack of physical touch because of social isolation?
Hey, this is Kara again. So interesting question, because just this past week on one of the IHI huddles, there were some pictures in the story shared behind a hug station that was created at a nursing home. So CDC doesn't specifically have guidance on hug stations, for example, but we do encourage you to find creative ways to promote socialization and visitation as long as you're able to do so safely, and continue to follow best infection prevention practices. So I think if you're doing something like this, just make sure that you are able to do it safely. Make sure that you are able to appropriately clean and disinfect any surfaces that are involved, and that people are still wearing their cloth face coverings or face masks, and outside of this, that they're still able to socially distance. I think that you can definitely, explore and get creative with some of those ways to try to stay in contact and socialize with others. Thanks.
Thank you. The next question is concerning PPE. What is the recommendation for universal eye protection in nursing homes?
This is Kara again. So universal eye protection is our recommendation. CDC's recommendations for universal eye protection are the same for all healthcare settings, and that includes nursing homes. You can find details specifically about this. There are further details outside of just our nursing home infection prevention guidance. If you go to our main COVID infection prevention guidance, you'll be able to find a little bit more about this. But what we recommend is, in addition to using eye protection, so a face shield or goggles for suspect or confirmed COVID, healthcare personnel should wear universal eye protection when they're in areas with at least moderate to substantial community transmission. So essentially, if you are in an area where there is sustained transmission or large-scale community transmission with a high likelihood of exposures happening, then you should be wearing eye protection at all times when you are providing resident care. And then, of course, in addition to that, there is, regardless of where you're located in the COVID level in your community, wearing a face mask, universal source control should be practiced as well. Thanks.
Thank you, Dr. Jacobs. Our next question is for Rockport. What are the best practices for managing social distancing on a memory care unit? This can be very challenging to keep residents 6 feet apart.
Hi there, this is Kristen. I think I can handle this question for the Rockport team. So yeah, it certainly is a challenge. One of the things that we've really done is involved our recreation staff and social service staff to really try to get the residents engaged in different activities. Really knowing the patients and kind of doing some individualized care plan approaches is really what has helped us in our facilities with maintaining social distancing. Keeping the residents engaged has been very successful for us related to that. And Carol, I don't know if you wanted to add anything else onto that.
Okay, thank you. We'll move on to the next question. This one is for testing, which will most likely go to Dr. Stone at the CDC. The question is, should we require a 24/48-hour COVID negative test before allowing a resident to return to the facility after being discharged from the hospital or as a new admission? Nancy, do you want to move to the next question?
Sure. This next question is for Dr. Jacobs-Lipka. This is concerning PPE. Can an N95 be worn for extended use between a newly admitted patient with no known COVID exposure or infection and other long-term residents, or does a new N95 need to be donned between patient interactions?
Hey, this is Kara. So yes, and so I'm going to answer the question in general first. So yes, an N95 could be worn for an extended period of time, and that may even mean between caring for a resident, like a newly admitted resident who's in observation and for which you're using full PPE, and another resident outside of that unit. If due to supply shortages, you're extending the use of N95 respirators as a part of your strategies to optimize PPE supply. I think the important thing to keep in mind is that this is not ideal practice, but it is one of the strategies that you may need to use in order to optimize the supply that you have. And so if you are doing this, you want to make sure that you avoid touching your N95 respirator. If you need to store it, you're doing so properly, like in a paper bag that you can close the top of, and that you're performing hand hygiene before you put your N95 on, before you don that N95, and then after removal. And then if you accidentally touch it while you're using it, you want to make sure you perform hand hygiene as well. And then of course, if that N95 becomes dirty or damp, you want to discard it at that point. And if you, I apologize, I got pulled away for a second, but if you wanted to go back to the last question and repeat it again, we may be able to answer.
All right. Thank you, Dr. Jacobs. We will come back. We will come back to that testing question.
Hey, Angel, it's Molly Stone. Just wanted to check and see if you could hear me.
Yes, we can hear you now.
I'm so sorry, everyone. Do you want me to just go ahead and address that question?
Yeah, sure, you can go ahead.
So the question was, should we require a 24 to 48-hour COVID negative test before allowing a resident to return to a facility after being discharged from the hospital? In the past, there have been those kinds of expectations during transitions of care where a center asks for testing prior to accepting them in transfer. However, we do not recommend that, and here's why. When a resident is transferred in as a new admission or readmission, we recommend that they are placed into observation status where people are using the full COVID PPE during their care for the first 14 days of their stay. And the reason for that is there may have been an exposure to SARS-CoV-2 at some point prior to their transferring in. And a single test that is done either in the couple of days before or right after admission would only be able to tell you just at that moment in time if the person was SARS-CoV-2 infected. But what it can't tell you is that they aren't incubating the infection and potentially could become infectious and symptomatic later in that 2 weeks time frame. And that's the length of time that people can harbor the virus and go without the symptoms of infection happening right away. And that's why a single test only tells you if it's positive that they should be placed in a COVID care unit. But if it's negative, it cannot guarantee that they're not still potentially at risk. Thanks.
Thank you, Dr. Stone. The next question we have is going to be for our CMS Division of Nursing Home group. And that question is, should outdoor visitation be stopped during a COVID outbreak in a nursing home?
Hello, this is Kathleen Lawrence from the Division of Nursing Homes. Can you hear me okay?
Yes.
Yes, ma'am.
Okay, good. All right. So regarding the outdoor visitation, if there's an outbreak, I think the way we've addressed that in our recent visitation memo is that kind of depends. The outbreak status can certainly affect a facility's ability to conduct outdoor visitation, depending on the facility and the extent of the outbreak. You know, perhaps it's one staff member or resident, which could be considered an outbreak, but the staff member doesn't return to work, or the resident's been isolated, so then maybe outdoor visits can continue. You know, we know outdoor visitation is preferred, and it can be conducted in a manner that reduces the risk of transmission. So, you know, we're really recommending definitely the outdoor visits. Obviously, the indoor we've recommended with certain precautions in place. So really, aside from weather or an individual resident's health status, that would be the main concerns and how the outbreak is being handled. So I hope that helps.
Thank you. This next question, perhaps the Rockport group could answer. It's, how do you manage social distancing on the nursing units among staff with so many nursing staff? Do you think you could address this question? Thank you.
Sure. This is Kristen for the Rockport group, Kristen Morris. One of the things that we did is we looked at sort of our nursing workstations and work areas, because that is a time when everybody's at the nurse's station where they would, you know, be closer together while they were documenting. So we did look at workstations and making sure that they were spread out throughout the hallway, pull down stations, things like that. Also looking at placement of med carts when they're done at the end of their shift. So any area that we thought about or we could see that they would be, it would be difficult to social distance, we really tried to hone in on those areas. So having CNAs be distributed throughout the hallways while they were doing their documentation versus all sitting together in one area. So that's part of how we approached that.
Great, thank you so much. So our next question is for the CDC, and it's around isolation, quarantine, and cohorting. Do you recommend new admissions who are PUIs to be separated from roommates who were exposed from their roommate that tested positive for COVID?
Hi, this is Namali. The answer is yes. We do recommend that those two individuals not be placed together. And that's because when you're determining where to house a resident, you really have to think about their relative risk of exposure to SARS-CoV-2. You know, while a new admission may have had some exposure, that level of risk is pretty unknown. Whereas a roommate of a recently diagnosed SARS-CoV-2 infected resident has a very concrete known exposure and a much greater risk for going on to potentially develop illness. And for that reason, we would not want those two people to be placed together. Thanks.
Thanks, Dr. Stone. The next question I have is again for the CMS nursing home team. That is, for healthcare workers who are not employees of the facility, but provide direct care to the residents, such as hospice workers, EMS, radiology techs, social workers, clergy, et cetera, do testing requirements apply in addition to the screening requirements?
Oh, hello, this is Kathleen again from CMS. So yes, the testing requirements apply because the individuals that you're describing are considered individuals providing services under arrangement, and that also includes volunteers. So our memo, the QSO 2038 nursing home memo on testing, recommends facilities prioritize those individuals who are regularly in the facility, like weekly, and who have contact with residents and staff. So we also note that the facility may have an arrangement with a vendor or whoever those individuals work for that requires them to be tested from another source. So as long as that works out with the required time frames for the facility, then that's how the testing can be accomplished also.
Thank you.
For that. Mm-hmm.
The next question, I think, is for the CDC, and it's concerning PPE. Can staff reuse surgical masks if optimizing PPE when going into quarantine rooms?
So I think similar to a prior question, this is really going to depend on your PPE supplies. Our recommendations for when we're talking about quarantine, or we're talking about new admissions, or we're even talking about potentially a unit where there is testing that's going on, and while you're waiting for those test results, for those residents, when we're talking about full PPE, our recommendation is an N95 respirator or a face mask if you are surgical mask, if an N95 respirator is not available. So it's really going to depend on the supplies that you have and how you're optimizing those supplies. And it is possible that you could get to a point or be at a point where you would need to reuse surgical masks. Again, it's not ideal. This is really dependent on the supplies that you have. And I think more commonly what we have seen and what we recommend is that if you are using those surgical masks, that you are first extending their use. So you're putting them on and you're not removing them, and you're trying not to touch them and wearing them for longer periods of time, such as throughout the day. But if you do need to reuse them, or even if you're extending reuse at any time, you want to make sure that if that surgical mask or face mask becomes damp or dirty or soiled, that you are discarding it. At that point, it should not be saved. Before you don the mask, before you put it on, you want to make sure you're performing hand hygiene. You want to make sure that if after you take it off, or if you happen to touch it, you are cleaning your hands. And specifically for a face mask or surgical mask, if it is being reused, the guidance is that you are supposed to fold it in half, with the outer portion folding into itself, and that can also be stored in a bag, like a paper bag that has a top that can be closed. Thank you.
Thank you so much. This next question is for Rockport. So how long do rooms need to be vacant before housekeeping goes in to do a terminal clean after a symptomatic resident is discharged or an asymptomatic resident?
So I'm going to ask Dr. Eslami to take this question. Oh, maybe she's having connectivity issues. So I can answer that. I mean, once the room is empty, we would go in, and housekeeping has been educated in the proper PPE to use, and they would go in and do the cleaning, the terminal cleaning. So it's everything. It would be pulling down, curtains around the beds. It's washing down the walls, all the equipment. So it's completely, every piece is cleaned in the room. But we do that as soon as the patients are discharged.
All right, thank you. The next question is going to be directed to CMS, Dr. Stone or Dr. Jacobs. Question is, what is the rationale to have long-term care change their CDC security clearance from level 1 to level 3?
Hi, this is Namali from CDC. The NHSN system is going to be releasing a new module that will allow centers to report resident-level antigen testing results. And this is part of an effort to be able to support providers who are using point-of-care antigen platforms who need to be reporting the results of all of the tests that are run as part of maintaining compliance with their CLIA waiver and use of this machine. But in order to have the ability to put in resident level information that will likely include some potential personal health information, the SAM security process and the level of clearance has to be increased. The level 1 clearance is used for centers that are just giving aggregate total results. There's not any individual level results being shared. And that's how the current COVID-19 module pathways are done. But to use this laboratory report and put in resident level information, a user has to have a higher level of security clearance. That's going to be an optional module at this time, but is really intended to help centers with their antigen test result reporting requirement. Thanks.
Thank you. The next question, I believe, is for the CDC, and it's regarding PPE. If a facility has a dedicated COVID unit with positive cases, would staff working on the other wings need to use full PPE for caring for negative residents?
Yeah, this is, so I think the answer to this question is going to be that it depends. Just because you have individuals with COVID-19 in your dedicated care unit doesn't necessarily mean that you will have residents in other wings of the facility who you are caring for using full PPE. But I'm going to walk through a couple of situations. So if you have new admissions or readmissions to your facility, then those are residents who you would be caring for those first 14 days in full PPE. Or if you at any point in time have someone who is newly symptomatic or has changed symptoms, or for whom you are concerned at any point has signs or symptoms concerning for COVID, then you are going to want to start using that full PPE to care for them. But then the situation that I think the question may be asking about is, if you have someone who you have found, you've newly identified, and you found that they have COVID, you've done that testing, you find that they test positive, and you move them to your COVID unit, then yes, in that situation, our recommendation is that you are ideally looking as broadly as possible at your facility. Because what we have seen is that in nursing homes, when we find a resident or healthcare personnel with COVID, we often find additional people who have the infection as well. And so we recommend that you look broadly, and ideally you are putting residents throughout your facility in transmission-based precautions and providing care using full PPE, and you're doing testing. Sometimes, given resource issues and testing issues, it's not possible to go that broad, so you at least want to be looking in that unit where that resident who was newly identified or found to have COVID was located at, and focusing your testing and your use of the full PPE that the question was asking about to all of the residents who at that point you don't know, they may be negative, but this is where you're going to be doing that testing and looking to see if you identify other residents. However, once you have done that testing and you've repeated that testing, after you have gone for a 14-day period with no new positive tests, then those residents, you are able to consider pulling back on those precautions, and you may not need to continue to use the full PPE. However, you still may have some residents in your COVID-19 unit, in that dedicated care unit, who you are using full PPE for. Thanks.
Thank you, Dr. Jacobs. The next question is for Rockport. Is the use of chlorhexidine advisable to use in a nursing facility to keep residents from getting COVID?
So Dr. Eslami, do you want to take this question, please?
Sure. I might need help from my colleagues at the CDC, but certainly chlorhexidine bathing has been done in some nursing homes in California and has shown that it has reduced MDROs for sure. Also, there's problems with chlorhexidine bathing in terms of turning sheets a different color and other sorts of side effects from using that type of preparation. I am not sure that it kills COVID. I would assume it does. I know it kills bacterial flora that live on the skin normally, but I am not 100% sure. So Dr. Stone perhaps can help me answer that question as to whether it's effective, chlorhexidine, against COVID-2.
Yeah, I completely agree with your response that the experience that we have with chlorhexidine bathing is really around the reduction of multi-drug resistant bacterial colonization. And there is no evidence of or guidance on how it could be used for respiratory pathogens like SARS-CoV-2. So at this time, we don't have a recommendation that it would be used for that purpose. And remember, the primary way that this virus is spread is through close contact and large respiratory droplets. So it's a different circumstance from the way resistant bacteria can be colonizing somebody's skin. Thanks.
Thank you, Dr. Stone. The next question is for Kathleen at the CMS nursing home team. The question is, for family visitation of their resident family member, does a nursing facility need to continue weekly COVID testing ongoing to allow visitation to continue even after they have tested the staff weekly for 2 weeks consistently?
Okay, so the testing requirements that are in place apply to staff, or as I mentioned before, including the individuals providing services under arrangement and volunteers and residents. And the parameters for testing are described in our memo, which came out with shortly after the regulations. So, but visitation may occur based on the guidance in our newest memo on visitation. So it's not really based on the testing. We do have some information about testing in the visitation memo that says that testing of visitors may be done for facilities who are in medium or high positivity counties, but the testing is not required. That's really up to the facility. And as long as the visitors adhere to the core principles of COVID-19 infection prevention, which are described in the memo, which are all the things I think we know about: masking, social distancing, et cetera. So I hope that helps.
Thank you. The next question is for the CDC regarding isolation, quarantining, and cohorting. Is there a criteria for quarantining residents with symptoms? Also, if a resident with a symptom has a roommate, should they stay in their room or be moved to the quarantine unit?
Thanks. This is Molly Stone. If a resident develops signs and symptoms consistent with COVID-19, they should be placed into transmission-based precautions where full PPE recommended for care of COVID-19 is used in either a single room, or they should remain in their current room until diagnostic tests are done and the results are back. While it's less than ideal to have that symptomatic resident continuing to stay with their roommate, it's preferred to keep them together, placing them both in transmission-based precautions, kind of caring for both the resident with symptoms and their roommate with the same level of precautions, and using physical barriers like a privacy curtain to try to reduce the risk of spread. It's preferred to do that over moving this resident, symptomatic resident with suspicion of COVID-19, into a new unit, like an observation unit, where people are placed with a much different level of risk and an unknown exposure level. So it's either a single room if one is available, or what we would call sheltering that resident in place with their roommate until the diagnosis is confirmed. And remember, we don't want to move that resident with symptoms to the COVID care unit unless that infection is actually confirmed. Thanks.
Thank you, Dr. Stone. The next question is for the CDC again, and this is around isolation, quarantine, and cohorting. Should a resident who has recovered from COVID-19 about a month ago be placed in a 14-day quarantine if sent to the hospital for care and readmitted?
Hey, this is Namali. So as we have learned more about COVID-19 recovery, we've seen that the risk of reinfection or being contagious to others is very low in the first 90 days following that clinical illness. And therefore, this recovered resident would not need to be tested or placed into quarantine during that initial 3 months from the time of their SARS-CoV-2 infection.
Thank you, Dr. Stone. The next question I have is again for Kathleen at our CMS nursing home group. Kathleen, the question is, with the expansion of visitation and allowance of essential caregivers, the guidelines state the essential caregiver must have a negative COVID test no greater than 14 days prior, but it is not clear if they need to be retested. Can you clarify?
Sure, I will try. The guidelines are referring to in the question, I'm not sure, maybe those are state guidelines. We know that some states or facilities have designated categories of visitors, calling them essential caregivers, based on their visit history or a resident designation. We at CMS are not distinguishing between these types of visitors and other visitors. So the recent visitation guidance should cover all types of visitors, including those who have been categorized as essential caregivers. And testing is not required, as I mentioned before, for visitors, but we do encourage facilities in medium or high positivity counties to test visitors if possible. And facilities should prioritize visitors that visit regularly, like weekly. And then facilities can also encourage visitors to be tested on their own prior to coming to the facility and, show the facility their negative test results. And if the essential caregiver, though, is actually more of a volunteer who provides care to residents, then this person would really need to meet the nursing home testing requirements for staff that are described in our other memo. And I know I keep mentioning these memos, so let me know if you need any links to those. So I think that's it for that.
Thank you. The next question is concerning testing. If the PCR test is inconclusive and you retest, in the meantime, should you put the resident in a private room on transmission-based precautions until the second PCR gives a conclusive negative or conclusive positive result? And I'm sorry, I meant to say that this was for the CDC.
Hey, this is Namali, and the answer is yes. We do recommend that that resident is cared for with full infection prevention measures like transmission-based precautions until that confirmatory test for either an inconclusive or an uncertain result is back. And so for this example, the resident would either be placed in a single room or potentially sheltering in place, cared for with full PPE until the SARS-CoV-2 is ruled in or ruled out. We wouldn't want them to get moved based on an inconclusive. And so we just care for them in a way that is as safe as possible without trying to shuffle them too much around. And for a healthcare worker, they would be excluded from work until that result was verified. Thanks.
Thank you, Dr. Stone. The next question I'm going to pose to Rockport, but just like before, if CDC has something additional to add, please do. When a nursing home resident who has had COVID returns to the general population after quarantine, can he be housed in a room with a resident who has never had COVID?
So Carol, do you want to take this for Rockport? How about you, Dr. Eslami? Do you want to take this one?
Sure. So I'm sorry, if you can just repeat it. So it's a patient that, or an individual that's coming out of isolation and going into the green zone, right? So they've already been isolated. So
I can repeat the question.
Yeah.
You want me to repeat?
Okay.
Yeah. When a nursing home resident who has had COVID returns to the general population after quarantine, can he be housed in a room with a resident who has never had COVID?
My answer would be yes, he can be housed in a room with someone who's never had COVID. Remember now that COVID exposed patient is hopefully, as Dr. Stone said, we're not 100% sure, but has made antibodies and should not be contagious or be able to infect anyone at this point. I don't know if the CDC has a different recommendation, but I would say that no separation has to be done at that point.
Yeah, this is Namali. I totally agree with that. Once somebody has met the requirement, the time-based and symptom resolution-based strategies for being taken out of transmission-based precautions, they can be placed with another roommate safely. Thanks.
Thank you, Dr. Stone. The next question is probably going to be for you as well. It is a question about NHSN, and that is, can you distinguish how a nursing home should count a resident who is sent to the hospital and that resident tests positive at the hospital? Should the resident be counted as confirmed or as admitted, readmitted?
Hey, this is Namali. I will try to answer this, but would also recommend to double check what I say with the NHSN tables of instruction. In this circumstance, if I have a symptomatic resident who I'm transferring to the hospital and they're in the, upon transfer, they are diagnosed and confirmed to have SARS-CoV-2 infection, that resident should be counted as a confirmed case because the illness, the infection really happened while they were, in my care. The admitted/readmitted column is to identify when nursing homes are bringing new residents new residents into their center in transfer, and that person has a diagnosis of SARS-CoV-2 and they continue to need to be in precautions because they haven't met the full time and symptom resolution-based criteria. So if the resident case is occurring in a resident that was in my care, I would count that as confirmed. Thanks.
Thank you. The next question is concerning PPE, and the questioner is requesting clarification on the PPE that is required for nurses who are administering aerosol treatments such as nebulizers to residents who do not have COVID and or no symptoms. And I'm sorry, that's for the CDC.
Hey, sorry, this is Kara. I was having a difficult time getting myself, off of mute and hitting all the buttons. So the question was regarding PPE that staff should be wearing if they are performing aerosol generating procedures for residents who are not known to have COVID-19, correct?
Correct.
Okay. So no matter what, you should always be wearing universal face mask use. Universal source control is something that should be practiced at all times. If you are providing care for a resident, whether you're performing an aerosol generating procedure or you're performing or you're performing some other kind of care, you also want to make sure that you are always following standard precautions, which means that you are thinking about any potential exposures that you could have. Most often we're thinking about exposures to blood and body fluid, but so you want to think about the type of procedure or what you're doing and potential risks of exposure that you may have, and choose PPE accordingly. So if you are performing an aerosol generating procedure and there is concern for some kind of splash or spray, then putting on eye protection like a face shield, or putting on goggles would be something that would be appropriate. Or if you're concerned for a splash, for example, you may need gown in addition to gloves. And so if you, I would say in thinking about whether you would be needing to use an N95 respirator, or making that decision, also making sure that this is an individual that you are not suspecting COVID-19 in. Because if you have any suspicions this individual could have COVID-19, then you definitely want to be wearing that full PPE. You want to be wearing an N95 respirator or face mask. If you don't have an N95 respirators, the eye protection, gown, and gloves. Thanks.
Thank you, Dr. Jacobs. The next question is for Rockport. When it comes to CPAP and BiPAP for sleep apnea in a COVID-positive building, what do you believe is the best practice for managing the risk, as long-term care doesn't normally have negative pressure rooms?
Yeah, this is Kristen. I can take this one for Rockport. So, ideally, you're correct. We don't have any negative pressure rooms in any of our facilities. So if it is required that a patient needs a CPAP or a BiPAP, ideally they would need to be in a private room in order to do that if they were COVID positive. We actually have not had to encounter this situation too often, but it definitely does come up. So that would be the best practice that we recommend to the centers.
Thank you. The next question is probably going to go to Rockport and maybe with some assistance from the CDC. The person is asking for clarification about not moving someone who is a PUI waiting for test results from their room to an observation or yellow zone. Is it okay for them to remain in the green zone with a roommate in the same room while waiting for test results? I would probably defer to CDC on this one, because we were, transferring patients to the yellow zone and treating them as a true PUI if they were, in that situation. So maybe the CDC wants to elaborate on that a little bit.
And just to double check, this is with somebody who had developed symptoms?
Yes, she's seeking clarification about not moving someone who is a PUI.
Mm-hmm. Yeah, again, it is about thinking through the level of risk for the person who you're moving, and if there's a plan to put them in a shared room, the risk of the person that they would be housed with. And if I have a strong concern that somebody has signs and symptoms consistent with COVID-19 and testing them, then ideally they are placed in a single room. And if that single room is on an observation unit, that may be okay. But what we worry about is moving that person into a shared room on the observation unit, because their potential, for having infection is higher. Our concern is certainly higher, and they may be put in a shared room with somebody who has a very different level of risk and unknown. Their roommate, on the other hand, has been exposed, and we know that we're going to have to monitor that roommate closely for the next 14 days and care for them as a PUI using full PPE. And that's why sheltering those two people together using full transmission-based precautions may ultimately be lower exposure to other places in your building, if that makes sense. We have heard from centers that they have had trouble sometimes trying to shuffle residents around based on just symptoms or, exposure in a roommate, and in hindsight felt that might have contributed to the spread of SARS-CoV-2 to other places in the center. So it is a difficult, and you have to be careful in your thinking through the options, but that's really why we want people to consider the real risk and exposure level before you put two people together. Hopefully that makes sense. Thanks.
Thank you, Dr. Stone. So we are almost out of time, so we're going to move to our next slide. So please join us for the next live Q&A session on October 22nd from 4 to 5 p.m. Eastern Time. Registration is required, and we will post the registration link in the chat for your reference. Next slide. So thanks again for your participation in today's call, and we hope that you found value in the topics discussed. Please take a moment to complete the survey from today's event. We use this information that you share to improve future sessions. Please have a wonderful day, and thank you so much to our panelists.